Fix 5, huh? Sorry, you're right. Oh my gosh, you're right. I guess we'll start at 4-5. I still feel like we're off a little bit on the WAG. Yeah.
Thank you.
I think we're off by a degree. And we may be off on orbit. Again? That's, I guess, I think it's better. Well, look at 4 is good, but 5 is off. I think we're okay. Maybe we're off on orbit by a degree. That's perfect. Nice job. And the WAG, so 4 is perfect, 5 is off. 5-1 is way off, but that's fine. All right, very good. But I want to see the sacrum. So if you can give me just a little bit, but that's going to change your WAG. Actually, that's really good. Let's keep that. All right, so everyone agree we're left 2-3, 3-4, 4-5, and then right 4-5. All right, so we're live. I'm Dr. Majin. Our patient is here with back pain and leg pain, worse on the left side. I'm going to give him some numbing medicine. How's he doing?
Just sleeping right now.
Okay. I'm going to give him a little num-num, little injection. Now, just lay still. Are you awake? It's Dr. Deuk. We're just getting started. I'm giving you a little local. You're fine. You're doing great. Yeah. All right, all right. Okay. Lay still. You're fine. Can you hear me? Dr. Deuk, I'm going to give you a little local. You feel a little stick and burn. Don't move, okay? Just don't move. Everything's okay. I just got to give you some numbing medicine. I apologize. You're doing great. Everything's fine. That's quite all right. A little bit on the other side. Just lay still. Now, if you feel pain, I want you to give me the old ouch, okay? And I will give you more numbing medicine. I know this is uncomfortable right now, but I just numbed you up, so that should help. 8 cc's injected. So as you know from watching these surgeries, I'm going to start with you awake until I get everything in where I want it, and then I'm going to put you to sleep, okay? Okay. All right. So if you have pain, just say ouch, but don't move. Okay. All right, so. That bothers you? Yeah. All right. Let me give you a little more medicine. When I say medicine, the numbing medicine, you know what I'm talking about? Yes, sir. Yeah. That's probably the iliac crest. It is. All right, so we need to be up a little bit higher. You're doing great. Lay still, okay? Okay. All right, very good. Is that current?
Yes, sir.
Okay. So we're going to start by accessing the 3 discs on the left side, and then we'll go to the right side. Okay. Shot? Are you comfortable?
Yes, yes I am.
Good. So we're passing the facet. I kind of like this patient participation. Shot?
Yeah, absolutely.
Shot? Huh?
I believe you have the knowledge.
Yeah, the knowledge. How's blood pressure? It's decent. If you can bring it down just a little bit, that'd be better. All right, let's get an AP. AP means anterior posterior, folks, for those of you watching. Anterior posterior is front back. So to guide myself, I need AP and lateral views. That's perfect. Nice spine you've got.
Thank you. I've been working hard at it.
Yeah. If you look at that left side, you do have that Bertaloti Syndrome with that weird transverse process.
Okay.
The one on the right side is fine, but the one on the left actually flares out and almost makes like a S1 type connection to the iliac wing.
Right.
Have you ever had that treated?
No, I have not.
All right. You're doing great. Just lay still.
Okay?
We're about to meet your first herniation right there.
Cool.
Shot? Can you tell?
Yeah, I feel a little pressure at
Mm-hmm.
the end there.
That's exactly where I am.
Cool.
Just lay still, okay?
Okay?
You're doing great.
Great, thank you.
Let me know if it's uncomfortable at all.
Sure.
Yeah. All right, so our first positioning needle's in place, and you could see what a difference it is doing, you know, anything but L5-S1. L5-S1 is really by much harder. It's in a class of its own. Yeah.
Yeah, sure.
All right. You're doing great. Let me give him a little more numbing medicine. Shot. So I need to aim up a little bit. I don't know if I can get all three with this incision. Shot. It's going to be tough to do. I'm probably going to have to do a second incision. Shot. There's the facet.
Yeah, that's painful.
Shot. That's uncomfortable. Shot. Hang in there. We're almost done.
Yes, sir.
Shot. There's the second herniation. Big tear. All right. There's no way I'm going to get that other one. I guess I could try. But if I have to do a second incision on this side, I do. I'd rather, you know, do that than struggle.
Okay.
Let me just see if I can do 3 on one side. Shot. It's kind of low. Yeah, I'm not going to be able to. All right. So let's give him some more numbing. I think I numbed him up higher up. But we'll just give you a little more numbing medicine, okay? I know. I don't know why this stuff hurts so much, but it does. That's all right. I gave him an extra CC.
Okay.
Just relax. You're doing great. We're almost done.
Okay.
Yeah, you can see that L2-3 is up there. Shot. Even this is kind of low. So, see what I can do. Shot. Facet. Shot. Might be able to get it here.
Yeah.
Shot. It's too low. Try not to move.
Okay.
You're actually shifting my needle.
Sorry.
No, it's okay. Shot. Yeah, as you contract your muscles, shot. I can feel it moving.
Okay.
It's funny. All right, there's facet, shot. So we're really close, right here. Shot. That should be it. I like to come in lower because you stay away from. Just lay still.
Okay.
Stay away from the nerve root. Shot. You can feel the herniation right there. Shot. So that's 2, 3, 3, 4, 4, 5. Everyone agree? You're good. You're okay. Num. Let's see. Hold on. 4 looks good. I guess we're good there. I may want to start a little bit higher. Let's have a little more local. You okay?
Yeah, just problem.
Yeah, it's the local medicine. I'm sorry about that.
No problem, no problem.
Look, a num-num
Ah,
shot.
ah.
Go ahead. A little bit. Yeah. Yeah, go a little more. Good. Lay still. You're doing really good. Yep.
Okay.
Shot. Let's see where we are. All right. So that looks good. Want to aim a little bit lower. Let's see. There. Shot. It's too low. There. Shot. 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 All right, going well. We're almost done with you being awake.
Okay.
AP. So we're about to enter the foramen on the right side at 4-5. I want to make sure my position looks good on the AP view as well. And we're not Chet, are you guys good with the x-ray picture?
Yes, we are, Doc.
Top left corner is not an issue?
Correct.
All right. All right, so I'm a little more lateral than I'd want to be. Let's go back to the lateral view and see where we are. I may want to redirect a little bit. Let me see his MRI. Yeah, good. Can you scroll side to side? All right, so actually it's not bad. I could get this to work pretty well. All right. You okay? Sean? You all right? Sir? Sleepy? Is he reliable? Shot? Shot? Yeah, I need him awake. All right, that's right on the disc, herniation. Give me an AP. So that should be good. So far, if you're watching, we've only lost about a drop of blood. It takes 20 drops to make 1 milliliter. A milliliter is virtually nothing. Yeah, that's perfect. Yeah, I like my trajectory. It's really lateral to medial, which is good because the spine is posterior, so I got a nice, I'm going to get nice and medial on the disc, which is what I want to do to repair that tear properly. All right, good. And you're pulsing?
Yes, sir.
All right. That's perfect. See it? Look at that. All right. We're ready. Everything is where it's supposed to be. So,
Thank you.
for the benefit of my patient
The other-
and his
the other
patients,
light, please. Yeah, thank you. The roof on, please. Thank you. Thank you.
all right, so basically, when I examined this patient, I asked him, where is your back pain? And what's interesting is, you know, we're not doing L5-S1. L5-S1 is down here. We're not treating that, okay? But most every other case we do. So it's unusual not to have a 5-1 problem. Anyway, he's got an L4-5 herniation on both sides. You can see the scar right here from his old surgery. I didn't do that one. He's got tears at L4-5 on both sides within the annulus fibrosis. So annulus fibrosis. And because of the tears, the jelly from the center has squeezed out, and he now has herniated discs on both sides at L4-5. He also has another disc herniation at L3-4 here. And he has another herniation at that's L2. L2-3. I apologize, L2-3. This is L3-4. So we're testing 2-3, 3-4, and 4-5. We're not doing anything with L5-S1 because he doesn't have pain down there. All right, so I need him reliable. You're sleeping so good. How you doing? All right, don't move your body. Are you comfy? Good, good, good. How long have you had back pain for? How many? 10 years. All right, he's had back pain for 10 years. And your back pain's in this area, right? All right. Are you comfortable? Ah, he knows. I told him I'd be delicate and gentle. How bad did that go on a scale of 1 to 10?
6.
All right. Is that where you typically get back pain? All right. Now I didn't push it too hard, so because we made a deal ahead of time. All right, but it's a 6/10 concordant at 4-5. Just lay still. All right. He's watched a lot of my surgeries, and he knows that the discogram can be quite uncomfortable, and he didn't want me to go too hard at 4-5. So we made a deal. We made a deal. So that may be why it's only a 6. You better now? How many of my surgeries have you watched?
3.
Okay. You know what comes next? How bad is that on a scale of 1 to 10?
8.
The highest it went was an 8?
Yes, sir.
All right, again, I'm trying to be nice to you, okay?
That's okay.
Is that where you typically get back pain?
That is a conservative, but I would say 80% of the pain is at L4-5, and this would be a 60%, a 6/10.
But you get back pain in that same area.
Yes, sir.
So it's concordant. So, you know, the 6/10 is just because I went easy, but that was at 4-5 concordant, and then 8/10 at 3-4.
Okay.
How many discs are we fixing today?
3. 3.
Are you better?
I'm okay. Yep, I'm okay. Fuck.
How bad is that on a scale of 1 to 10?
8 to 9.
All right, my friend. Well, the L2-3 was a 9 out of 10. So we need it. It's a good thing we're fixing it. We're doing all of them.
Okay.
Is that where you get pain typically?
When it's aggravated really bad.
Yeah. All right. You get to go to sleep. When you wake up, we'll be done.
Thank you very much.
You're welcome. We found the source of your pain.
Okay.
Nighty night. Sweet dreams.
All right.
All right. So, you know, he's going to watch the surgery later, tomorrow, tonight, and he's going to get to see that, you know, when he came into the office and he said he had back pain, and we did his consultation virtually.
Yeah.
Yeah. Count out loud for me from 1 to 100, would you?
Yes, sir.
Keep counting till I tell you to stop.
Okay.
All right.
100.
No, start from 1,
1,
2,
2.
3. Good. Keep going.
Okay. 4.
Basically, we did a virtual consultation like we do for a lot of our patients, and he pointed to where his pain was. I looked at his MRI. He's got herniated disc at, and really it's a bulging disc at 2-3, a bulging disc at 3-4, and then a herniated disc at 4-5 on both sides. And based on where he was showing me his pain was, it wasn't just at 4-5. He wasn't just pointing there. He was actually pointing higher up. So I knew the other disc herniations were also causing his pain. And that's why I recommended the 2-3, 3-4, 4-5, because that covered where his pain was really bad. So knowing that, I came into the operating room knowing I'd do a discogram. I'd either confirm or rule out those discs as pain. And based on the discogram, they're clearly causing pain. Can you show them, Jordan, where the annular tear is on both of those discs? L2-3, L3-4. Actually, do all three. So there's a tear there in the back of the disc. There's a tear there in the back of the 3-4, and there's a tear there in the back of the 4-5. If you look at those tears, the worst one is 4-5. It's a grade 5 tear, and that's the highest tear you can get. Now the one above it is a grade 4 tear, and the one above that is probably a grade 3 to 4. And it really just takes a grade 3 tear to be painful. So he's got grade 3 to 4, grade 4, and grade 5. All right, we're going to get started. Is that okay?
Yeah.
So we're going to start with a bottom disc, 4-5, I think. Yeah. Shot. I can't tell you too many details about this patient, but he's a very interesting person, and he's actually a doctor, I can tell you that. And I can tell you he specializes in the treatment of pain. Yeah. You didn't know that, huh? It's really interesting. I can't really give too many details. I don't want to give his identity away, but yeah, that's about it. Point is, he's here because he knows what we do, and he knows we can cure pain, and that's what we're going to do today for him. I feel really good about it. You know his history, right?
Yep. Spoke to him.
Huh? You spoke to him? Shot? We do get a lot of doctors. A lot.
This mechanism of injury since when he first realized it.
Yeah. 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 Let's just say that he almost spent a year here. Okay. All right, we're at 4-5. We're going to enter the tear. And it's going in pretty easily, meaning it's a big tear. So the beauty of this surgery that everybody can appreciate, that really understands how to treat back pain, is that we're actually making a little cut here. All the rest of the tissues, the muscles and stuff, we're leaving them alone. We're just spreading them open and literally entering the bad disc through the tear where the herniation is. So I'm basically pushing the herniation back in, and I'm not causing any new damage to the disc. It's such an incredible surgery. I fell in love with it when I first saw it because it's so effective, but also so minimally invasive, and no metal, no fusion, no implants, and no hospital. Shot. It's just patients love it for the most part, and it allows them to heal their disc naturally. All right. Shot. That's perfect. So now we have our endoscopic tube in. Now, just because you watch me do the surgery doesn't mean you can start doing these surgeries. It takes a lot of skill, and I hide that. You know, if you ever watch Formula One, you watch Lewis Hamilton or Max Verstappen race, it just looks like they're driving a car around the track, right? You look at it and go, anyone can do that. But actually, their inputs into the steering and the braking and the throttle, those three inputs, are mastered, like to a level that you can't even imagine the detail. So it just looks like driving, but it's not. This just looks like I'm hammering a nail in somebody's back, but I'm actually doing something in a very controlled and detailed manner. So let's go ahead and show our audience why herniated discs cause back pain and leg pain. Can you run that, Chet?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Okay. Welcome back to the operating room here at Deuk Spine. Look at that herniation that just shot out. Just in time to catch that. We are at L4-5. This is his, in my opinion, oldest and worst herniation based on the MRI and based on his history. Yeah, right there. It won't even come out in one piece, but you can see the softness of it. There's a pinkness to the white. That's inflammatory tissue, the pinkness. Pink is always, blood vessels, and you don't normally get blood vessels in a disc because it's avascular. It doesn't have blood vessels. So when you see blood vessels, it's abnormal. It indicates an ingrowth of blood vessels in a process called neovascularization. It's part of granulation tissue formation, which is part of chronic inflammation. I need the laser on, guys.
Ready, please.
All right. So once again, this is the L4-5, and we are cleaning this thing up. Do we have any questions from the audience, Chet?
Yes, Doc. We got a question from Tom from YouTube.
Yes.
What would make you abort a procedure?
What would make me abort a procedure like this? Great question. If I cannot get into the disc for some reason because of the patient's anatomy, I would abort it. Or more commonly, I would say, would be if we're having trouble with the airway of a patient. For example, if they're not breathing well and they're not ventilating well, they're not moving air well, we would have to abort the surgery. We do everything we can do ahead of time to make sure every patient that we operate on is a good candidate. We do medical clearances, EKGs, blood work, get a good history, but sometimes patients respond differently to the actual anesthetic agent. Some people respond in a more predictable fashion where we do what's called a titration. We give a little bit more and they get a little deeper. We give a little bit less and they get more awake. And that's like the perfect scenario. But there are times when some patients just don't respond normally. And maybe they get too sleepy and then they stop breathing. So we'd have to wait and try to wake them up. Sometimes we actually have to abort surgery because they don't start breathing again. And we have to get them on their back and secure their airway and ventilate them. So, anesthetic reasons are that. And then anatomical reasons where I can't get access to the disc to do the surgery. That would be another reason. I've aborted a couple of surgeries for that, anatomical reasons as well. Good question, Tom. Yeah, if you have to abort a surgery for a patient who's not ventilating well, we can't just start over again. We've got to let them recover and check them out, make sure everything's good, and then bring them back at a later date, and maybe try a different strategy that's maybe safer. We've had to do that a few times. Whenever we abort surgeries, it's always for patient safety. All right, this is a pretty bad tear here. So this patient's been dealing with this tear for a while. He says he's had back pain 10 years. I believe him. This disc here that we're working on is probably one of his original sources of back pain, because it's, to me, one of the most degenerated based on the MRI, but also what I'm starting to see right here is that golden color is calcification, called dystrophic calcification. And dystrophic calcification is a natural process in your body that occurs when you have damaged tissue. So whether it's your kidney or liver that's damaged, or it's your disc that's damaged, over time you can get calcification of those tissues, called dystrophic calcification. And it's little spicules of calcium deposits that form. It's not the same as a bone spur. They're microscopic little calcium deposits inside the tissue, typically associated with scarring. Great questions.
Doc, another question from Tom from YouTube. Can medical students shadow you?
Oh, I would. Tom's asking from YouTube, can medical students shadow me? We love medical students, PA students, nursing students. We love them all. Yeah, absolutely, they can shadow me, for sure. They just need to get in touch with Ron in HR. I think, anybody know Ron's phone number? Okay,
I do.
good. Why are you guys calling Ron? You want a shadow? All right, Ron's phone number is 321-775, and here's where I need some help. Whoa, 749, no, don't give his cell phone number. Sorry, we're getting, huh? 775-0848? There you go. 321, because we live in the Space Coast, 775-0848, 0848. Or go to Duke Spine's probably website and look for our employment page, hiring page, and just submit a request to shadow. We can take students for any amount of time, whether it's a week, a few days, a few months, a few years, whatever period of time they're interested in. Of course, we'll screen our students to make sure there's no, all of our people that work here have to have a clean background. So that would be the only consideration. But otherwise, we're happy to have students here. We're located in Florida. We're located in what's called the Space Coast. That's why the area code is 321, because it's named after the 321 rockets launching, basically. And yes, we love education. We love teaching, and we have medical students quite often come and rotate through here. Thanks for asking, Tom. All right. So far, the blue stuff, as you know, is the degenerated nucleus material that's come out through the tear. Now, that white stuff right there is normal disc. That's normal nucleus, so I'm going to leave that alone. And we're just about done with this tear. You can see that's the top of the tear right there. This is all scar tissue. Everything okay, ladies? There's a little epidural fat, some epidural veins, Batson's plexus, This is just at the outside of the disc. And remember, this is the left side, L4-5. We're going to be doing the right side L4-5 next. Later. Not next. I misspoke. I meant that will be the last thing we do. We're going to move next to L3-4, right? Again, the tear is lateral as well. You got to make sure you get that. Just got to be careful out there. All right. I'll wait. All right, so. Yeah, lay still. You're doing great. Don't move. Don't move. What is it? Yeah, but you know, I'm near the outside of the disc. This is the most painful area of the herniation and tear. So you guys can see the fat, right? Pretty cool. Little vein right there on top of the fat. You've got nice fat cells. Look at that. That's beautiful. You can actually see each and individual fat cell. You guys see that? It kind of looks like the eggs of a fish. You know, like a frog's eggs or something. All right, but those are not fish eggs. Those are fat cells. You can see every single fat cell glistening individually. And a couple of little veins on top. Tell me when he's deep. Is he ready? You got a nice view of your fat. Where else can you get a nice view of your epidural fat? But Deuk Spine Institute. Tell me when I can proceed, doctor. Huh? All right. I do have to get that out of the way so I can do my job here. Yeah. Yep. That's just my stomach groaning. Want me to wait a little more? All right. So I'm going to clean this up. I'm almost done here. And then I'm going to swing it and go lateral and just get that lateral tear as well. But basically, I'm in the foramen right now. If I were to look to the left, we're going to see the L4 nerve root. And if I look to the right, we won't see anything. All right, can I proceed?
Yeah.
Okay, don't move. All right. Let me have the grabber. So, yeah, he's just a little lighter than we want him, so we're going to put him a little deeper right now. Get him more sleepy. You're fine. Let me know when I can keep going. This would be a good time for questions. Any more questions?
No, Doc.
All right, why don't you go ahead and show the video of how the Deuk laser disc repair actually works. What do we do here? Let me know when I can proceed, doctor.
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. the laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Welcome back. We are just getting ready to finish this L4-5 disc. We're just giving our patient a little more medicine to get him to be a little sleepier. And then I'm going to finish this and we'll be done with this disc. Right at the outside of the tear, that's the most painful part of the tear. So we know patients typically experience a little more pain when we're near the outside of the tear. A lot of this herniation here, you can see it's kind of whitish. That means scar tissue. So there's nucleus in there plus scar tissue. This is annulus here. Tell me when. Huh? That's good. Come on. This is the worst part of the tear at 4-5 on this side. That's why he's not happy with me, because I'm working on the most painful area. So what's interesting about this whole process of inflammation is that inflammation brings with it nerves, pain nerves, and blood vessels. And it turns out that the longer the inflammation goes, the more pain nerves it brings. So chronic inflammation brings more and more pain nerves to the area of inflammation. It's almost like it's trying to tell the body, hey, we're hurting here. Can you do something to stop this? And that's what we're doing today. We're doing something to stop the pain, because we're going to get rid of the source of inflammation. And therefore, we'll stop the production of little new pain nerves in the area. He doesn't need more pain nerves here. He needs less. So the laser helps clean him up, gets rid of all the extra pain nerves, and stops the inflammation. All right, Doc, I need another minute and I'll be done here. And then he should settle down a little bit while we get the next disc accessed. How are we doing on irrigation? Ladies? Huh? Take your time. Take your time. No rush. I mean, I'm about to stop anyway. It looks like we're coming up on the bag. I bet you we could time the bags, you know? Huh? I'm pretty much done right now, so. What was that? I'm happy with that. Yep, let's clean this out. Scope off. Scope off. So we're done with this left L4-5 tear. We're going to now move on to the next disc. We put a little antiseptic. How come I don't have any suction here? I need suction on this tube. Yeah. It's always good when suction is sucking. Thank you. So here comes one tube out. I'm going to put a little pressure on the paraspinous muscles. Luis, you got disc right here? Some pieces there. We're going to bring our fluoro back in so I can navigate to the next disc. Remember, I've already got the needle where I want it, but I got to put the guide wire and bring in the dilator and then finally the tube. I'm really, don't move. What's going on? You're not doing that with the fluoro, right? Yeah, lay still. Interesting day. Okay. All right. So we're at 3-4 now. Big tear there. Shot. I'm in with the guide wire. I can see it. Is he down? Yeah? Is he good? Berndes, I can't hear you. You want me to wait? Yeah, take your time. I'll just set everything up. Is he, it's a little more challenging on the anesthetic side, huh? All right, so I'll tell you what, Jordan, while we're waiting, why don't he's moved a little bit. Yep, still in the process. Lay still. Flynn, go up to the top, see if you can help out. So check it out, Flynn. For patients to move their trunk, they got to leverage their elbow onto the armband. Can you make sure his arms are fully in surrender so he can't move himself? They like to tuck and roll. So I think he's doing a little tuck and rolling. We don't want that. We've got all the straps on. Let me know when you've got him. Yeah. So do you want me to start? Shot. Is that where we are? Shot. Let's get some num-num. Shot. Are we ready, Dr. Berndes?
I think so. It's hard to judge. Barely breathing.
Seems like we had a couple of those patients lately, huh? Is there something in the water? Can you shot? Any way you can use like a biz monitor or something? Shot? Huh? Would that help, you think, or no? And that's because of propofol or fentanyl? Got it.
Gotta keep your head down there, all right?
Try not to move.
L3, right?
Doc, I got a question from YouTube
Yeah.
from Jacob. What muscle relaxer is the best for back pain?
That's a great question. There is no right answer. Certain muscle relaxers work better for certain people. We use, yeah, it's fine. We use Robaxin. Robaxin is safe and effective in most people. But about 10% of the patients it's not going to work for. Shot? So it just depends on the individual patient. Every patient is different. Shot? I think we need to go a little bit further. Shot? Shot? Good. That should be good. Shot?
Suction on, suction on, please.
So there's a lot of different muscle relaxers out there. I think one of the best are tenazidine, like Robaxin, methocarbamol.
Scope on, please.
Those are safer.
Thank you.
And then you can get into more powerful but more addicting, like Soma.
End on the screen, please. Thank you. And clean, turn off this light, please. Thank you very much.
Laser. And then, of course, Valium is a really powerful muscle relaxer, Valium. But it's also just it can make you weak. Like I've had patients where we gave them Valium for muscle spasms and they couldn't walk because their legs were weak. So that's too much of a side effect. You know, it's not good. How you guys doing? Keep him safe, all right? If he's going to move a little bit, it's fine. But I'd rather him be breathing and ventilating than I don't mind a moving target. That's the best we can do. So most powerful muscle relaxer is Valium and maybe Soma afterwards. Of course, there's other muscle relaxers that are even more powerful that we cannot give to people unless they're having a tube down their throat. Those are anesthetic muscle relaxers, and we don't prescribe those. We just give them to people who are intubated and we're ventilating them. But just for writing pills, we prefer Robaxin. But like I said, in a couple of patients, it won't work. So maybe 1 out of 10 patients, it won't work. We have to try something different. It doesn't mean we have to try something harder, stronger. It just means different. It's amazing. Somebody could actually be on Valium and it's not working, and then they go on like Robaxin and it works. Or vice versa. Okay, our patient seems to be a bit more comfortable right now. Thank you. Our anesthesia team is really earning their keep today. You guys doing all right? Is the patient okay? Uh-huh. Yeah. Great questions, by the way, from our audience. So, just about done here at L3-4. That should be the last of the tear right there. This is going to be the more painful part, Dr. Berndes. I'm out at the periphery. you're watching, for those of you who are wondering, is spine surgery. We are inside a herniated disc that's causing pain, and we're repairing it. This is a new technology. It's called the Deuk laser disc repair. It was pioneered at Duke Spine Institute by Dr. Duke Majan, me. And what's unique about it is I do what's called an annular debridement. The first surgeon in the world to do an annular debridement, and the first surgeon to publish it. You can see this, quite interesting. That's all relatively normal nucleus, the white stuff, and the blue stuff is the degenerated. You can see how the degenerated is out at the periphery where all the inflammation is happening, and the white stuff is more central. So I want to preserve as much of his normal disc as I can. So I'm kind of just hugging the degenerated herniation. This is the back of the disc. Those fibers there at 12 o'clock are posterior longitudinal ligament fibers. So we're right at the back of the disc now. Remember, this is L3-4. Next, we're going to do L2-3. All right, I'm pretty much done here. Lasering the herniation is kind of like mining for little veins of gold. You see the vein right there of blue? That's what I'm after. I think we're done here. See if we can see the nerve root. Yeah, right in there. It's kind of hard to see though. I want to just get the last bit right here. Nerve root is being protected by my tube. A little bit of fat there. Pretty much done.
Right, Tom, Carpal, please. Thank you.
A little antiseptic, betadine. You're doing great. I like to talk to the patients just in case they're awake. They may not be. Usually if they're moving, it could just be reflexive. Thank you, Louis. All right. Great job, everyone, so far. Come on in, Jordan. So now we're going to move on to the third spot we're fixing, L2-3. We tested that one as well. And remember, that was a 9 out of 10, concordant. By the way, most surgeons wouldn't be treating these small tears with bulges because they don't think they cause any symptoms. That's because they're missing the cause of the patient's pain. Shot. Let's go up to 2-3. Good. A little pressure.
Yes, sir.
Shot. Perfect. Shot. Very good. You can see the guide wire. I'll make an incision. Knife down. We're going to put the dilator in. Shot. Perfect. Just lay still. Wait a minute.
Yes, sir.
All right, good. Let's sew that. If you have it, might as well use the time wisely. Pick up. Good. I think you have teeth on there, right?
Yep.
Just let me know when you're ready for me to proceed, doctor. we're just gonna close this.
Doc, I got a question from Teak from YouTube.
All right, shoot.
Has any surgeon in the United States gotten trained by Dr. Deuk and doing this procedure in practice?
Honestly, I didn't hear the question. Just slow down a little bit and a little bit louder.
Okay. Has any surgeon in the United States gotten trained by Dr. Deuk and doing this procedure in practice?
Yeah, that's a great question. So, you know what's funny? Thank you, doctor. The answer is, I don't know. And here's why. Because I broadcast these surgeries. We've been doing this for 8 years. And we honestly don't know who's doing it. You know, in the old days, we used to teach people in a hospital at a university. And now I'm teaching people online. And it's right there. The truth is, I really don't know who's doing it. I always joke about it and I say, don't try this at home. But the reality is I really don't think anyone should be doing this without formal training. In other words, they should be here with me for a year. It takes a year or more to learn how to do these surgeries. So I guess you could say I don't know if they are or not. But I've been teaching this technique for 8 years now, just like we are today. I have interest. Shot? In this procedure, but I don't know who's doing it. Shot? I think we made a little progress there. Don't move. Shot? I'll be honest with you, if you want to do this kind of surgery, I would really recommend that you start with open surgeries, like laminectomy, microdiscectomy, fusions, where you really get to learn the anatomy quite well, and you're able to manage complications should they arise. Shot? For me, I would be most comfortable training a surgeon as long as I know they have some type of backup where they can have someone helping them in case they have a problem. Or they're able to manage it themselves, yeah. Shot? All right, we're at L2-3, perfect. This is the last on the left side we're gonna do. Then we're gonna go do that one disc on the right side. There are two people who know the most about this surgery besides me. Actually, three. Luis is probably the most knowledgeable. He assists me on all my surgeries. Dr. Patel and my son. My son actually helped me publish the papers, so he's an author on the original publications. So I think eventually there'll be more and more people doing this technique. Nowadays I go online and I see there are more and more endoscopic surgeons, but they don't do the surgery the right way. This is another one of the damaged discs. If you're thinking about going into spine surgery to help people in chronic pain with back pain from herniated disc, what I would tell you is very important is the physical exam. It's very important to spend time looking at a patient's back and understanding where pain comes from. Because the biggest problem in the world right now is that most doctors, by the way, look at all this blue. This is all damaged disc. I mean, you can never tell on the MRI how bad this was until you get in here and stain the disc, and then you see how much degenerated nuclear material there is. This is pretty extensive. You know, it's unfortunate. His pain's been going on for 10 years. What I could tell you is if he had maybe come and seen me after 6 months or a year, all this could have been avoided. But people don't know about this treatment. That's the problem. And many of them don't believe it, that it actually works. It's too hard to believe because so many other people are telling them that there's no way to fix this pain. That's why we broadcast too, so people can see the results of the surgery. All right, we ran the video on why do herniated discs cause pain, right? Let's run that video again. Can you do that for me, Chet?
Yes.
Give me a countdown.
3.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
Right. All right, welcome back. Thank you, Chet, for showing us that video explaining how a annular tear gets inflamed from a herniation. So it's a 1-2. It's the first step is the annular tears, and a second step is the herniation. Actually, it's 3 steps. Second step is the nuclear material herniates. The third step is the inflammation sets in. So everyone knows what gangrene is, right? Why does gangrene happen? You need 3 things to happen. You need an injury to a limb where you have an opening or an exposure to a bacteria. You need poor blood supply, and then you get an infection as the third step. Yeah, anaerobic infection. The point is, it's not just one thing, it's 3 things happen. Same thing with a herniated disc that's painful. You get the tear, you get the herniation, and then you get inflammation. Annular tears by themselves are not painful. But annular tears with a herniated disc, now that can become painful and inflamed, but not all of them do. It's all scar tissue. There's inflammatory tissue in the tear. Just about done. I need 2 minutes, maybe 3. It's amazing how much damage there was. You really don't see this again on the MRI. It's invisible almost on the MRI. 99% of doctors would miss it, not knowing what to look for. I'm sorry?
Maybe it's the amount of inflammation making it harder for me to stay to
Honestly, don't. True.
Just have it for a long period of time.
That's the whole point. Yeah, I just said it. The longer your inflammation, the more pain fibers you have. The more innervation, pain innervation. But propofol works centrally, right?
It doesn't have any control of it.
Huh?
It potentiates GABA essentially. It doesn't have any
Oh, I see what you're saying. So you're saying the pain is what's waking him up because it's more pain fibers.
when we use so much propofol, we can't use a lot of narcotic because those are synergistic.
Ah,
Be careful with how much narcotic you use.
fascinating. Yeah, I don't think most people know that propofol is not a painkiller. It just puts you to sleep. Fascinating. So there you go. We need to figure out a way to block the pain from the disc. How do we do that? They're type C fibers.
We do laser disc repair.
Well, yeah, but how do I block the pain?
Oh, during the intraoperative.
Yeah.
Yeah.
You know what? We could try. Maybe we could just run some lidocaine down there. I don't know. I mean, if that got intravascular,
You put lidocaine in the fluids.
right, that's what I'm saying, in the irrigation. But what if that infiltrating got intravascular or intramuscular?
Well, then they use it in liposuction all the time.
They do?
Yeah.
What do you mean?
Liposuction fluids.
And that doesn't cause a cardiac effect? Huh?
We use a lot of it.
Wait. We need to learn more about this. This may be revolutionary right here. We may be able to avoid so much deep sedation if we can run either lidocaine or marcaine down this tube. Huh?
I wouldn't use marcaine because of the blood vessels.
All right, so you use lidocaine. Like a what, 1/4%? 1%? 1/4% lidocaine. Is that right?
Put in, every bag you can put in like about 50 milligrams.
50 mils. All right, I want you to come up with a proposal. I want you to think it through while I'm gone. If you think we can do it safely, I want to try it. I mean, I don't think 1/4% lidocaine will have any effect on the nerve function, like giving a paralysis of the nerve temporarily. You know, we want them to be able to get out of here after an hour, but you know, I don't want them weak in the leg from their nerve or numb, right? But they're not driving anyway, so maybe it's okay. They wear off by the next day. Huh? Don't know. I don't know, but I think it's worth exploring. I really do. Because if we can use less of the propofol sedation, it's safer for the patients. They have less risk of obstructing. And I'm just about done here. And then if we can control the pain better, you know, topically, that would be fascinating. Huh, Luis? All right, anyway, we're just talking about the future, how we can make this better. That's how improvements are made in medicine. People get ideas, they test them out. You see how it's happening right here, right now. All right, what do we got here? Man, there was a lot of scar tissue in this disc. A lot worse than I could think based on the MRI. Just gonna clean this and we're done. Then we're gonna switch sides. We're gonna go to the other side. That should be good. That should be good. Let's have the grabber. Just one quick grab and make sure we're not leaving any herniations in there. Oh, yeah, there's one. Good thing I did that. See how blue that thing is? Oh, all right. I don't feel any more. Just gonna take a peek. We're done. Let's take a look, see if we can see the nerve. Again, the nerve is hidden in all that soft tissue there, but we're done. We've got the other side to do, okay? Just one level. Any questions from our audience?
No, Doc.
Okay. Just cleaning out the antiseptic, betadine. Yeah. Done. Let's switch sides. Let's bring the fluoro in, and we'll do the one L4-5 on the opposite side. We've got about 15 minutes left. What? So, again, this patient is a young, healthy male who's had chronic back pain for 10 years in the L2, 3, 3, 4, 4, 5 region of his back. That's what I determined on his examination. And when I looked at his MRI, I saw for sure L4-5. And let me tell you something. 99% of spine surgeons would have just treated L4-5. Okay? And guess what? He would still have pain. And he would come back with more pain, and it would be above the fusion at L3-4 and L2-3. You understand? This happens all the time, folks. It's what you want to avoid. You don't want to have surgery at one level when you need 3 levels fixed. So it's important that you get a doctor who can determine where all the levels that are painful are. And sometimes those painful levels are really hard to see because it's just a disc bulge. And that bulging disc, which is really representative of an annular tear, is the cause of their pain. If I had just fixed L4-5 like his other surgeon did, he would still be in horrible pain. Shot? Shot? You need her? You're doing great. Lay still. Almost done. Shot? Shot? I can definitely feel it inside the tear. You're okay? Yeah, he feels that because that is his painful disc. Shot? You're all right. Let's pull back the dilator a little bit, just a little bit. Sometimes we'll get a little tissue trap between the dilator and the tube. You're doing great. Yeah, you do it.
Check. 1.
Yeah. Shot? Perfect.
Doc, I got a question.
Done. Yes.
Teak from YouTube. Can you perform a thoracic and a lumbar at the same time?
Can I do thoracic and lumbar surgeries at the same time? Yes, I can. So the question from YouTube was, can I do a thoracic Deuk laser disc repair and a lumbar at the same time? Yes, I can, and I have. It works pretty well because you just have to expose a little higher up, and then you can do the thoracic spine. We've done probably 3 or 4 patients that way. Hey, don't move. All right, you just hold them still. He's not happy with me. Here we go. So again, pretty messed up disc. Laser would probably be done in 10 minutes.
Doc, I got another question from Jacob from YouTube.
Yes.
What's the best for nerve pain?
What's the best for nerve pain?
Correct.
What's the best medicine? What's the best treatment?
They just wrote that.
So, you know, if the nerve pain you're talking about, so it depends on what nerve pain you're talking about. So there's all kinds of nerve pain in the human body. One example of nerve pain is something called carpal tunnel syndrome, where you get a pinched nerve in your palm of your wrist. The best treatment for that is to go in and unpinch it by cutting the tendon that runs over the nerve. It's called a carpal tunnel release. Another kind of nerve pain is, that's good, Luis, very good. That's good. Another kind of nerve pain is a pinched nerve in your back or in your neck. That's a pinched nerve root. The best treatment for that is to unpinch it with this surgery you're watching right here. Another kind of nerve pain is something called occipital neuralgia. That's where you have a pinched nerve at your skull base. It actually causes really bad pain shooting up over your ear. Feels like a shock. Causes these headaches. The treatment for that would be to deaden the C2 nerve root with a rhizotomy. So it just depends on, honestly, what nerve you're talking about. But there's also a lot of people that call just regular pain nerve pain, but it's not. I mean, let's put it to you this way. All pain is mediated through nerves, so it just depends on what kind of nerve pain, what the source is, to tell you the best treatment. There are some medications that are pretty good, but they have side effects. Things like Lyrica or Neurontin, gabapentin, amitriptyline. So there's just too many treatments to really say one is the best, but if you have a pinched nerve in your neck or back from a herniated disc, the best treatment is what you're watching right here, Deuk laser disc repair. The reason we do this surgery is because it is the best treatment. As a spine surgeon who has a lot of experience with different surgery techniques, there's not anything that I can't do surgically. And because I'm able to do everything out there, from artificial discs to fusions to laminectomies to microdiscectomy, laminoplasty, foraminotomy, I could do all of it, endoscopic surgery, open surgery. Because I can do every single spine surgery available, I get to choose from all those things what's best for my patients. And what do you see me do every single week? This surgery. Why? Because this is the best. It's the go-to surgery when you have a herniated disc, spinal stenosis, pinched nerve. All right, this is our last disc we're fixing. Huh? Okay, that's fine. Yeah, we're almost done. But we do need irrigation for like another probably 10 minutes, 5 minutes. I'm always going to hand it to you in exactly the same spot. Luis? That's a big herniation right there. That is a big herniation. It tore. It was coming. Tore again. Oh, but that's a good one. Let's show him. He's going to want to see this. Look at that, baby. You see that? Smack
Yes,
it in.
Doc.
Smack it in the ass, and let's give it an APGAR score. You can actually see, if you look carefully, you can see like almost inflammatory tissue in there. Let me try to drop it off. It's like I feel like I went fishing and caught a shark. Like right here, you can kind of see a pinkness to the tissue. That's where all the blood vessels from inflammation are grown in. Anyway, that's a herniation. That was a good one. This is the patient's right side, L4-5. Just about done. He's pretty comfortable now, huh? What, you just got him loaded good? Huh? Yeah, he's not responding or anything. What does it just take? The body just needs to get leveled up. Hey, I need the laser, guys.
Four levels to find the anesthetic plane. Hey, now you got that big piece of disc out. He's fine.
Right? So go take a break. There's another piece there. It's hard to believe that just a few years ago I was doing all these major fusions. Look at all the pink inflammatory tissue from that tear, guys. This is what we have in our video. I discovered this. We discovered it at Duke Spine. All that's where all the pain comes from. And you just gotta zap it away. That's why herniated discs are painful. It's the posterior annulus inflammation. All right. Just about done. Oh, you're kidding me. See how the tear comes low in this one? And you still have the annular fibers at top. So this is a low tear. It's in the low part of the annulus. Look at the annular fibers there. So this tear happened kind of at the bottom of the annulus. And herniation is down here. Right there, you all see it, all that blue? Just about done, 2 minutes. So our next case is our fourth case for the day. It's a treat. The guy has 2 herniated discs in his thoracic spine, and he's here to have the Deuk laser disc repair done on both of them. That will be a 2-level thoracic. All right, just about done. 1 minute. What's the issue?
No issue. It's just an extra.
Yeah, T89, I'm going to talk to him and figure out if we're going to go left or right, because the report says one side, but his complaints are on the opposite. So,
I will stay like this, Jordan. Like this. Yeah, stay like this.
all right, 10 seconds. Look at that creature coming out of there. He's like, don't leave me here. Don't worry, we got you covered. That reminds me of that movie, The Thing, just coming out. Did you ever see The Thing? Huh? John Carpenter's The Thing? Tell me you did. What? Berndes. What do you do at night? Never mind. I don't want to know. Come on. You gotta watch some movies, dude.
Carpal, please.
You never watched The Thing? John Carpenter's The Thing? That's a classic from the 80s.
I love you.
You like sci-fi?
Yeah.
Go watch it.
Thank you.
I'm telling you. It's one of the best movies ever made. Great story. I mean, totally original. And scary. If you like scary sci-fi. Uh-huh. Oh yeah, no, this is like that, but even, maybe even, I can't say better than aliens, but equally good.
So this gentleman got 1,100 milligrams of propofol.
1100, I don't know what that means. I don't know if that's a lot or a little. Let me have a stitch.
Well, put it this way. A colonoscopy anesthetic is about 300. An ERCP is about 600.
Well,
This is about twice as much as a...
you keep going. I'm trying to help you. All right, any questions?
You can,
Yes, Doc. Andre from YouTube. When
Hi.
when a patient has a herniated disc in cervical and lumbar area, can this be done same day, or does it depend on how many levels?
Yeah, cervical and lumbar cannot be done the same day. We have to break it up into 2 days. It's not safe to do cervical and lumbar the same day. All right. All the way down. There you go. You want to do the last one? Light on. You want the light on?
light on. No, that's okay. That's perfect.
All right. Come on over and do it. You can instrument tie it. We're done. Oh, did you see how small the incisions were, folks? Right here. So we got 2 on one side, 1 on the other. Good job, Luis. Hey, great work, everybody, as always. That was a tough one from an anesthetic standpoint. It was a good one from a surgery standpoint because it highlights how the MRI can totally mislead you and mislead so many doctors. Can't trust. Sometimes you can't trust the doctor's interpretation of the MRI. That's why we want to look at MRIs ourselves and the patient. All right. Dldr, left, L2-3, 3-4, 4-5, right, L4-5. Great job. All right, type your questions up for me. I'm going to come and answer them for you in just a few minutes. Why don't you go ahead and run the comparison of Dldr with fusion.
Okay.
Thank you.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement, whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, Dr. Ardukmajian here. We have just finished a very complex 4 discs or 4 spots, 4 herniations is probably the best way to describe it. And we did the left side L2-3, 3, 4, 4, 5, the right side L4-5. This patient came to us with chronic back pain. And when I did his exam, we really weren't 100% sure right away. We needed to kind of figure out where is the pain coming from. So we did a virtual visit, and through the internet and Zoom, I was able to see where his pain was. And he really pointed up a little higher than L5-S1. So I looked at the MRI. L5-S1 looked good. It didn't have any problems. I looked at L4-5. It was herniated with tears on both sides. And then I looked at 3-4 and 2-3, and it was herniated on the left side. And indeed, he had pain from the L2-3, L3-4, L4-5 discs. And I knew that based on my knowledge of the anatomy of the spine and where the spine is relative to the skin. So when people point, my pain is in this area, I know which discs they're pointing to. That said, when I got into the operating room today, we put needles in each disc. We did a discogram, and indeed, each of those 3 discs were causing his typical back pain that he gets every day. The L4-5 was probably the worst, but I made a deal with the patient ahead of time that I wouldn't push too hard. I would be very gentle because he didn't want to have a lot of pain. So I did a little push, and he had 6 out of 10 pain, just enough to confirm that it was indeed the source of his back pain. That was L4-5, and then at the top 2, I pushed a little bit harder, and we had like 8 out of 10 and 9 out of 10 pain. But again, concordant pain. What does concordant pain mean? Well, let me show you what concordant pain is. Come on over here, Chet. Does your arm hurt?
Yes.
No, it doesn't.
No, it doesn't.
It doesn't hurt. But if I hit it, it hurts, right?
Correct.
But that's not pain that you have every day, is it?
No.
So that would be dissimilar or atypical pain that I created by hitting you.
Correct.
All right. But if you have pain in your back that you have every day, and then I put a needle in the disc, inject a little dye, and it recreates the pain that you get every day, then I've just found the source of the pain. Now the intensity with the injection may be, high intensity that you don't normally get, but it's the location of the pain that really matters, and the fact that that disc causes the pain. So a discogram is a very, very powerful, useful tool to confirm that the disc is the source of pain. If somebody comes to me with back pain or neck pain and they just have back or neck pain, and I do a discogram and it doesn't create any pain, I would not treat that disc. So when you watch my surgeries, it seems like every disc that I'm treating is causing pain. That's because over the years, and I've been doing this for a while, I've gotten pretty darn good at figuring out where pain comes from, based on the MRI, based on the patients pointing to where their pain is. So once again, it highlights the fact that doctors need to get better at diagnosing the source of pain. And the problem is literally less than 1 in 1,000 doctors treating back and neck pain. Less than 1 in 1,000 doctors can actually figure out where the pain's coming from. That's really the biggest hurdle we have to overcome if we want to cure chronic back and neck pain. Making the right diagnosis as to the source. The second hurdle we have to overcome is treatment. We got to get the treatments right. And that's what we work on every day at Deuk Spine Institute. All right, our first question is
From YouTube, Whiteside 91. You mentioned earlier in the surgery about using local anesthetics to reduce the amount of sedation. how would you implement such a change?
Ha, I love it. Audience participation. It's the best thing in the world. So Whiteside 91, thanks for asking the question. We were just kind of talking and brainstorming. Really, that's what it comes down to. And that's the beauty of science, okay? And maybe other things too, but I'm kind of a science guy. Anyway, I was talking to Dr. Berndes about the patient, and he was complaining that, oh, the patient's taking so much propofol that they require so much sedative to put him to sleep. And of course, he was sleeping nicely most of the time, but when I got to those really painful areas, he seemed to wake up. And that's because the amount of sedative or sleep he was in was okay until we really stimulated the pain fibers, and then it wasn't okay. He woke up. So I guess the point is that if we're able to deliver medicine through the tube that I'm working through that could block the pain fibers inside the disc as I'm working on them with the laser. And what hurts the patient is the fact the laser is right in that painful area of the disc, zapping away that painful tissue. So it really does hurt. Think about it this way. You get a wooden splinter in your finger, right? It's all swollen and painful. Karen? No. I need coffee. Sorry. Yes, just a half a pot. Hi. All right, thank you. Anyway, imagine.
You do not need coffee.
I do. I need coffee. I still have another surgery to do. Anyway, if you get that splinter in your skin, right, and you touch it, it hurts like hell because it's inflamed. So now somebody wants to go and dig it out for you. So they're messing around in that painful tissue. It's even more painful than normal. So that's what I'm doing when I'm fixing somebody's annular tear and herniation is I got that laser in there. It hurts. Trust me. It's already painful to begin with, and then you add the laser on top of that, it hurts. So what we were saying is maybe if we put some numbing medicine in there, that the numbing medicine would allow it to be a lot less painful. And then we wouldn't need so much propofol sedation. So that's what we were talking about, delivering the numbing medicine through the endoscopic tube. The reason I haven't done that in the past is because there are these nerve roots right next to where we're operating. And if the numbing medicine gets on the nerve root, come back, Joe, then it can actually numb the nerve root. And then after surgery, the patient will be like, oh my God, my leg's numb. And so basically, if their leg's numb, that's bad. They won't be able to walk. And so as spine doctors, we never want to numb up the nerve roots because the patient won't be able to drive. They won't be able to walk. They may fall. So we want to avoid that. But what we were talking about is if we use a really low dose, like 0.25% lidocaine, and that's what we're discussing. Should we use Marcaine? Should we use lidocaine? And Dr. Berndes recommended lidocaine 0.25%. So it's such a low concentration, we should be able to maybe shut down the pain fibers, but not shut down the big nerve root. So we're going to try it, and when I get back in a couple of weeks. Great question. No more questions. I hope you enjoyed the surgery. Next up is a thoracic disc herniation, T8-9 left approach with the Deuk laser disc repair. And then we're going to do a left approach T12-L1. So this patient has two herniations. He's been blown off by his doctors all over. There's nothing we can do to help your pain. He's got pain right at T8-9. He's got pain right at T12-L1. And he's tired of living in pain. So he traveled all the way here from Tennessee, I think. Where's our last patient from? Tennessee. And we'll be doing his Deuk laser disc repair shortly. Thanks for joining us.